Okay, everybody, welcome back to part 3 and the last part of chapter 15, cardiovascular emergencies. Okay, so we talked about, let's go back into quick review here. We have talked that the heart is known as a myocardium. Okay, we talked about how the septum divides the heart into left and right hand sides. We talked about the atriums and the ventricles, top and bottom. We talked about the aorta, which is the largest artery in the vein, or largest artery in the body. We talked about the blood flow through the heart. Blood is returned to the heart by the vena cava, superior and inferior vena cava. That brings back deoxygenated blood to the heart, and blood comes up to the upper right atrium, goes down to the ventricle by passing through the tricuspid valve, goes from the bottom right ventricle out through the pulmonary vein, out to the lungs, picks up oxygen, becomes oxygenated, drops off a bunch of waste, returns to the heart via the pulmonary vein, comes back to the upper left atria, goes down through the bicuspid valve, otherwise known as the mitral valve, down to the bottom left ventricle, and then it goes out through the artery, through the aorta. Goes out through the aorta to the rest of the body. When it goes out, the aorta divides it into a couple different things. One, it gives blood to the carotid arteries that supply the brain and the face, the subclavian arteries, which are under your clavicle bones, and that's delivers oxygen to your upper extremities. The subclavian artery, when it enters where the shoulder, right where the upper part of your arm is, that becomes a brachial artery, and then when it passes the elbow, it becomes the radial artery. Okay? The aorta continues, goes up out of the heart, comes around, starts going down the back of your body, down around where your belly button is. It turns into the iliac, and then from the iliac all the way down to where the groin area is. Then it divides into the left leg and the right leg, and when it goes into the leg, it becomes the femoral artery. You have the arteries. The arteries are the big ones, and then as the blood goes down and starts entering the legs and parts of the body, then the artery becomes smaller and it becomes an arterial, and then when it gets really, really microscopic, then it becomes a capillary, and then down to the capillary, that's where perfusion takes place. Okay. The exchange of blood and oxygen, the exchange of oxygen, carbon dioxide, or CO. And then it delivering through the capillaries, and then it drops up all the oxygen, picks up a bunch of waste, and it turns into a vein. Okay? Or capillary, then the capillary starts to turn blue. Blood starts coming back to the heart through a venule, then to the vein, and then back to the vena cava. Okay? So we talked about that. We talked about circulation of blood through the heart. We talked about the SA node and the AV node. We talked about the bundle of His, and we talked about the Purkinje fibers. Take a look at those on page 631. We talked about automaticity, how the heart actually shocks itself, creates its own electricity. We talked about the sympathetic and the parasympathetic nervous system are the two components of the autonomic nervous system. The autonomic nervous system is a nervous system that just basically takes care of all the automatic procedures in the body. We don't have to think about doing it. The sympathetic nervous system is known as a fight or flight. Okay, get your body ready for active activity. And then the parasympathetic nervous system helps to calm you, relax you. Okay, let's see. We talked about what stroke volume is, the amount of blood that goes through the heart with every time it beats. We talked about, how blood leaves the heart, goes to the brain, goes to the body, inferior, superior. Talked about how it breaks down. We talked about the number of places you can check the pulse at, the carotid artery, brachial, radial, popliteal, dorsal pedis, also known as the pedal pulse. We talked about cardiac output, which is the stroke volume multiplied by the number of beats within 60 seconds. That gives you the cardiac output. But again, that's something we don't know. We don't need to know that. We just need to know, do they have a pulse? And is the pulse sufficient? Okay. We talked about the pathophysiology of ischemia. Infarction means the death of tissue. Okay. Ischemia is the chest pain. We talked about arterial sclerosis. And very quickly, you have arterial sclerosis and arterial sclerosis. Arterial sclerosis is the buildup of crap within the arteries. And when it builds up, something breaks off. It comes to thromboembolism, which is a piece of cholesterol floating around and finally gets to someplace really, really small and blocks blood from going beyond it. It creates an occlusion. It's a clot, basically. The clot can be something very hard or it can be very gelatinous. And in that, it blocks tissue off to the heart or to the brain, resulting in a stroke or an MI, acute myocardial infarction, which is a heart attack. Okay, and that can lead to cardiac arrest. We talked about the acute coronary syndrome. We talked about the two different types, angina and an MI. We talked about the two ways that they can get MI taken care of. They can either get that clot taken care of with medications, which is called thrombolytic, or they can do it mechanically by clearing the artery, and that is called angioplasty. We talked about the signs and symptoms of an MI. We talked about if your heartbeat is more than 100 times a minute, it's called tachy. If it's less than 60 times a minute, it's called brady. We talked about VTAC and VFib. We talked about what it is to defibrillate the heart with an AED, what defibrillation actually means, which is shocking the heart. We talked about flatline, which is asystole. We talked about an irregular heartbeat, which is called an arrhythmia. We talked about CHF, cardiogenic shock. Cardiogenic shock is basically the heart is not pumping blood sufficiently to support life, and it's cardiogenic shock. And you guys all know the 4 things you do for somebody in shock. You put them in a position of comfort, provide them high flow O2, keep them warm with a blanket, and rapid transport to the hospital. Okay, and let's see, we talked about the hypertensive emergency, signs and symptoms of that, and we talked about an aortic aneurysm and a dissecting aortic aneurysm or dissecting aneurysm. Okay, now, here we go, talk with the patient, dealing with the patient, okay? Insert my timer. I don't want to bore you guys too much. Okay, cool. So, you're dispatched to 250 Main Street for a 50-year-old man complaining of chest pain, difficulty breathing. What could it be? Could it be angina? Could it be an MI? Could it be a heart attack? Could it be a panic attack? Who knows? You don't know. Dispatch never tells you anything. And a lot of times when dispatch sends you out, sometimes what they say the dispatch is for is not actually what's really, really happening. So, you get dispatched. You show up on scene. You park in front of the house. According to your 11 steps, I don't know if you guys have already gone through these with your teachers already, but you have a medical patient assessment. You have patient assessment, medical, and patient assessment trauma. First thing, your 11 steps. Your 11 steps are the same whether you've got a medical patient or you've got the trauma patient. And those 11 steps are broken down. What you do at scene actually broken down in the categories. And each category has a list of things. First one is scene size up. Scene size up consists of 5 things. Scene safety, BSI. Okay? Number of patients. How many patients do you have? So it's scene safety, BSI, number of patients, MOI or NOI, mechanism of injury or nature of illness. Consider additional resources. Do you need extra help? Do you need additional EMTs or do you need man parts? You need to call the fire department. You may not know yet. Okay? And consider C-spine stabilization. Well, if you're still outside the house, you don't know if you need to grab C-spine stabilization yet. Okay? So some of those can go unanswered. You walk in the house. Okay? Walk in the house, you see the patient, he's sitting at the kitchen table and he's going like this. Oh my God, this really hurts. Okay? The next step, first step, scene size up. Next step, second step, primary assessment. You're going to do a preliminary assessment of the patient. You're going to do it very quickly to help you determine whether you need extra manpower, to help you determine whether this is going to be a scoop and screw or whether it's going to be a stay and play. A scoop and screw situation is one that you think the patient's condition is bad and is deteriorating or could deteriorate very quickly, and you want them in the hospital as fast as you possibly can. That's a scoop and screw. A stay and play is, okay, I don't see any life threat. I don't see anything where the patient's going to die and start to die in the next 5 or 10 minutes. I can spend an extra 1 or 2 minutes with the patient, talking to them, getting more information, and getting the vitals. So, first thing in the primary assessment is going to be verbalize your general impression of the patient. Based off of the 5 things you already have right here, what's your general impression of the patient? You see the patient, he's sitting at the dining room table, he's grabbing his chest, and he's saying, wow, this really hurts. And, oh man, this really hurts. Okay, you see and hear that he might be having some problems breathing. You need to make a determination. Number 1, is he having a problem breathing because of the pain, or he's honestly having a hard time breathing? Why is he having a hard time breathing? Is that because of the pain, or is that just in addition to what's going on in the heart? So you have verbalize general impression of the patient, determine level of consciousness. Determine LOC. You determine the LOC by using the AVPU and the person, place, time of it, the ALC times 4. AVPU is, are they alert to verbal, painful stimuli, or are they unconscious? AVPU. AVPU. Are they alert? Yes or no? If they are they completely alert like you and I are right now, or are they somewhat in and out of consciousness? Or are they unresponsive? They're completely out. They don't respond. You yell at me, smack me, kick them. We don't kick, you don't smack. But they're completely out. Or you yell or you pinch them and they respond. Well, when they respond, if you yell to them, your verb AVPU, alert or unresponsive. If they're alert or they're unresponsive, do they respond to verbal or painful stimuli? Remember, AVPU, V, verbal stimuli, P, painful stimuli. Verbal stimuli. Hey, I'm Brian and I'm an EMT. I'm here to help you. What's your name? Oh, my name's Frank. Okay, he just responded to verbal stimuli. Okay. P, painful stimuli. Person seems like they're almost out of it. Hey, you okay? You okay? Nothing. We don't do sternum rubs anymore. We pinch the ear lobe. We pinch the top of the shoulders, or we pinch the tricep bicep area. Do they respond to to painful stimuli? Okay. After that, if they're talking to you, you need to determine their awareness and consciousness. And you do that by ALC times 4. Person, place, time, and event. Do they know their name? What's your name? My name's Frank. Okay, that's person. Place. Frank, where are you today? Well, I'm in my dining room. What the hell do you think? I called you. I'm at home. Okay. Person, place, time. Frank, do you know what day of the week it is? Do you know what time of the day it is? And I don't mean like 10 o'clock or 11 o'clock. Does the patient know whether it's in the morning or nighttime in the afternoon? Okay. Do they know what day of the week it is? Do they know what month it is? Do they know what year it is? Okay. Ask them a tricky question. You have to see if they give you the right answer. An event. Person, place, time, and event. Event. What's going on? Frank, why'd you call me here? I'm having chest pain. What do you think? Okay, good. He answered you correctly. But there are times people are out there and they have chest pain. They don't tell you because they're having chest pain. They call you because, oh, my toe hurts. Okay. But you see that they're having chest pain. They're acting like they have chest pain. Okay, so person, place, time, and event, ALC times 4. If the person can answer all 4 questions correctly, they're ALC times 4. You tell the doctor when you give the report, Doc, I have a 50-year-old male, ALC times 4. But if for some reason Frank doesn't know his name, doesn't know where he is, he just knows the event. I called you because I'm having chest pain, and they know that it's November, and it is November, but they don't know their name and where they are. Then you say, okay, the person is ALC times 2. Minus person and place, or they're ALC times 2, and they're only alert to time and event. That's it. However you want to tell the doctor, that's all. But they need to know that. Okay, and the earlier they know that, the better. So determine level of consciousness, and then you do your ABCs: airway, breathing, circulation. Okay. While you're talking to the patient, you're going to look to see if you can find any life threats. A life threat is 2 things: bleeding or breathing. Are they breathing? Yes or no? If they are, great. Are they breathing too slow or too fast? Are they bleeding? Yes or no? If they are, is it a major hemorrhage or is it a minor hemorrhage? Okay, a hemorrhage is a leak. Okay, a bleed. Is it a major bleed or a minor bleed? If it was a minor bleed, put a Band-Aid on it. If it was a major bleed, stop the bleed first. Okay? Those are life threats. Airway, breathing, circulation. ABC. Airway. Is the airway secure? Is it patent? Are they unconscious and on the floor and they're like this? If they're on the floor like this, their airway is probably closed. So you just do a head tilt, chin lift, and you open up the airway. Or if it's a trauma patient, you think that you think that they injured their head or their neck or their shoulders, you think there might be some damage to the spinal cord, you do a modified jaw thrust. Okay? So that's airway. If you have to open the airway, do you have to use an OPA or an NPA? I don't know if you know what an OPA is or an NPA is. Hopefully you guys do. So if you do, which device do you use? How do you measure it? How do you insert it? Okay? That's airway. B for breathing. Are they breathing? You know the average respiratory rate for a healthy adult is what? 12 to 20? 12 to 20 breaths a minute. So if the person is breathing more than 20 times a minute, what do you do? If the person is breathing less than 12 times a minute, what do you do? There's an old saying that says that we use less than 8 over 28, or less than 8 more than 28 ventilate. If the patient is breathing 8 times a minute or less, we have to breathe for them. If the patient is breathing 28 times a minute or more, we have to breathe for them. When we breathe for them, we're going to use a BVM, a bag valve mask. And use a bag valve mask with supplemental oxygen at 15 liters per minute. That's considered high flow. And you guys should know your airway chart by now. We're starting to know it. And the saturation rate with a BVM on high flow O2 at 15 liters per minute, saturation is 90 to 100% oxygen. Okay? And you breathe for that patient once every 5 to 6 seconds. Okay? Breathe for that patient. Okay? Circulation. Airway, breathing, circulation. Circulation. Pulse. Check the pulse. Check the pulse on a radial pulse. What are you doing when you're taking a pulse? What are you touching? You're touching their skin. You're touching the radial to check the radial pulse, but you're checking the skin. The skin is the largest organ on the human body. Okay? You're going to check for skin color, temperature, condition at the same time. Okay? So you can feel the pulse. Once you find the pulse, how does the skin feel? Is it a really hot day, 4th of July weekend, and the person's skin is cool and clammy? Like they just walked out of a steam sauna, that's how clammy it is. But it's not really hot. It's not hot the way it would be, but it's really cold. It's cold and clammy. It's cool and clammy. Should the skin be like that on an 82-degree day? No, it shouldn't be. What if it's a really, really cold day and the person's skin is really hot and it's dry? No, let's say same thing. 4th of July weekend, and the skin is really, really hot and it's dry. Well, it should be a little bit moist. It's a really hot day. Shouldn't the guy be perspiring a little bit? It shouldn't be dry. And it shouldn't be really, really hot. It should be normal. Okay? So you're going to check the skin color, temperature, and condition. Skin color. Is it very pale? Any cyanosis around the mouth? Okay? Temperature, hot or cold? Condition. Is it cool, clammy? What's it like? Okay? You can tell somebody's dehydrated, especially in children and the elderly. It's called Tugor, T-U-R-G-O-R, T-U-G-O-R. It's called, you're going to create a tent on their skin. And that is, you take their hand or you take their arm and you just take the skin and you pinch it like this. If a person is hydrated, when you let go, the skin bunches right back into place. See how it goes right back into place? But if you have somebody who's dehydrated, a child, an infant, or an elderly person, and you squeeze the skin like this, and then you let go, and it stays tented like that, okay, that means that they're dehydrated. As soon as you notice that, you want to call for ALS right away because they need to get an IV started in that patient. Okay, you're going to need advanced life support. And there's a lot of things that cardiacs and medics can do that basics can't. Okay, but they're going to evaluate the patient the same way we do to determine whether we need ALS or not. Okay, so that's patient assessment. You need to have your patient assessment skills down to a science because every single time you get dispatched to take care of a patient, whether it's a 12-year-old boy who scraped his knee on the bike path, a 65-year-old man complaining of chest pain, a 32-year-old mom who's pregnant, she's getting ready to give birth, or an 82-year-old lady who's complaining of seeing and hearing things, and it's really not the case. She just lost her husband a year ago. They have no kids, and other friends have died, and she's by herself. She has nobody. She's living by herself in this house, all by herself. She's lonely. There's nothing wrong with her. She just wants somebody to talk to. And it does happen where you have the elderly or the lonely call 911 for some ridiculous reason, and they just want somebody to talk to. Okay? So you need to evaluate your patient. You need to assess your patients. You need to know what the vitals are: blood pressure, pulse, respiration. Those are the three main ones. You take a patient into the hospital and you don't have those three, that they're going to look at you like you're an idiot. Okay? You need to know the blood pressure, pulse, respiration. The pulse, well, the blood pressure tells you whether the cardiovascular system, whether the heart's working correctly or not. The pulse, is the heart working correctly enough? Okay, blood pressure, pulse, respirations, are they breathing? Are they breathing adequately enough? Those are the three you always have to have. Now, some other ones you can do. You can do a neuro check. It's called FAST, face, arm, speech, and time. Okay, face, are they looking at you? Is one side of the face like this? Okay, have them smile. When they smile, do both sides of the face come up at the same time, or does one droop? Okay, speech, are they talking to you like I'm talking to you right now, or are they talking to you like a baby and they're slurring their words, like they can't get out what they want to say? Arms, so face, look at the face. Arms, have them take their arms, go like this. They can heal their hand. They can have their fingers out like this or make a fist. Have them close their eyes. Okay, are both arms staying steady, or is one drifting down, or is one drifting? It's usually drifting down. Okay, speech, they talk to you, and time. How long has it been since somebody has noticed you've been acting like this? Okay, scene size up. We already talked about scene size up. Primary assessment. What's your general impression of the patient? Okay, are they breathing correctly? So after you do your scene size up, primary survey, the next step, after your circulation, the next step is what they call history. History consists of the OPQRST and sample. You know what that is. Okay? Okay? Okay, I apologize. So you do the ABCs. After you do your ABCs, at this point you are then going to make a patient transport decision. You have evaluated their airway, their breathing, circulation. You have evaluated their level of consciousness, whether they're conscious or not. And if they're conscious, are they unconscious, conscious, or somewhere in between? You determine whether it's a mechanism of injury, which would make them a trauma patient, or nature of illness, which would make them, it could be a cardiovascular emergency or a respiratory emergency that they're going through right now. Okay? At this point, with that preliminary information, you are then going to make a decision whether to transport the patient, scoop and screw, or stay in play. Okay? The next step is what they call history taking. History taking for the medical patient is called OPQRST and sample. OPQRST is a mnemonic you can use, and then sample, SAMPLE. OPQRST. OPQRST. O stands for onset. Did this come on suddenly, or did this come on slowly? You called me for chest pain. Did the chest pain come out of the blue within the past 5 minutes, or did it start last night? P, provocation. Does anything make the pain or the discomfort feel better, or does anything make it go away? Sitting up straight, moving your arms, taking a deeper breath, whatever. OP, provocation. Does anything make it feel better or worse? Q, quality. Can you describe to me what you're going through? If it's pain, is it stabbing, crushing, squeezing, tearing pain? Describe the pain, or describe the discomfort to me. OPQR, radiation. Does the pain or discomfort go anywhere else? You say you're having some chest pain. Does it just here, or does those go to your arm, your jaw, your back, or your stomach? Okay. S, severity. Okay. On a scale of 1 to 10, how would you rate it? 10 being the worst pain you ever felt in your life, 0 being no. So no pain, 0, the worst pain I ever felt in my life, and 10. How would you rate that? Somewhere in between. And then T, time. When did it start? Onset is how did it start? Quickly, suddenly, or slowly? Time is when did it start? It started 15 minutes ago. It started last night at 6 o'clock. Okay, cool. So that's OPQRST. The next mnemonic is going to be sample. Okay, signs and symptoms, allergies, medications, passport and medical history, last oral intake, and E for events leading up to. Signs and symptoms. What's the difference between a sign and a symptom? A sign is something that you see. The guy sitting there, he's going like this. Oh, Okay, that signifies to me someone's having pain in the chest. That's a sign. A symptom is what they tell you. Yes, I'm having chest pain. I'm having difficulty breathing. Those are symptoms. A for allergies. Do you have any allergies? Why is it important to know? Could he be having the chest pain because he has allergies to peanuts and his wife just made him a sandwich, roast beef sandwich, but she had a peanut butter and jelly before, and she had a little bit of peanut butter oil residue left on the countertop where she put his sandwich together, and he is that sensitive to peanut oil or peanuts that even if there's a minuscule amount on his, even oils, it can send him into anaphylactic shock. So could he be having the chest pain because of that? Could he be having chest pain because his doctor gave him new medication and he's having an allergic reaction to that medication, and that allergic reaction is giving him some chest pain? Okay. Does he have any allergies to other medications? He has allergies to one medication. He goes to multiple doctors, and Dr. A and Dr. B don't know what he's getting. So Dr. B prescribed him a new medication. He's taking the new medication, and now that medication is having a bad reaction with one of the medications Dr. A gave him. Okay? So that's allergies. M, medications. What medications are you taking? Are you taking a medication for your heart? Do you take nitro? Do you take an aspirin a day? Okay? Because, like I said about the allergies, the medications, he might have an allergy to the medication that Dr. B gave him, but he doesn't know it. Okay, well, he's having a reaction to it now. He'll find out when he gets to the hospital. Medications, SAMP, past pertinent medical history. Is anything that's going on right now, do you have anything in your history, your medical history, that could be related to what's going on now? Well, yeah, I had a heart attack 5 years ago. Oh, great. Or I had a heart attack 3 months ago. Oh, great. Okay. Or it could be like, nope, I've never had this, but this is the first time it's ever happened to me. Okay, cool, no problem. When was the last time you had something to eat? Last oral intake, L. SAMPL, last oral intake. When was the last time you had something to eat? Why? I could have indigestion. It could be angina. It could be agita. Okay? It could be I'm allergic to something that I just ate, and I didn't know I was allergic to it. Okay? Let's say you're allergic to garlic, and you had shrimp scampi at a local restaurant. Came home 45 minutes ago and had this discomfort. Oh, okay. I remember like 20 years ago, a lot of Asian restaurants used to put MSG, monosodium glutamate, in their food. It's a chemical that helps make vegetables and fruits look brighter when you cook them, but people had and it's supposed to bring out the flavor, but it also was very bad because a lot of people were allergic to it, and people didn't know until it came out that a lot of Asian restaurants put MSG in their food. Now they don't do it that much anymore. Let's see. SAMPLE and events. What were you doing right before he called us? You could have been just sitting there watching TV or talking with a friend and the pain came on. Or it could be that he had a heart attack 3 months ago and he's been home and he was outside, he was raking leaves. And he overexerted himself. Okay? So that is the history portion of it. Then you have the secondary assessment. Secondary assessment is going to consist of when you evaluate the affected body part in the body system. If someone calls you for chest pain and they have a cardiac history, are you going to worry about their fingers or their legs? No. Are you going to worry about their ears? No. Going to concentrate on the chest. What if somebody calls you about abdominal pain? Are you going to worry about their chest and they said the pain's down here? Not really, but because they're so close to each other, but I'm really going to concentrate on the stomach. Well, what's in the stomach? Up here, it's the heart and the lungs. What's down here? Your liver, your kidneys, your diaphragm, because the diaphragm is the organ that separates the chest cavity from the abdominal cavity. Good test question. Okay? So, let's see. What's next here? Sample will be QRST, fluid examination. Let's see. After you examine the affected body part and body system, you are then going to take your vital signs. Your vital signs of blood pressure, pulse, respiration. As you know, normal blood pressure for a healthy adult is 180 over 60. No, I'm sorry, 120. Oh my gosh, it's 120 over 80. The normal blood pressure for a healthy adult is 120 over 80. The normal respirations are 12 to 20, and the normal pulse is 60 to 100. So is the blood pressure high or low? Is the respirations less or more? Is the pulse slow or fast? what's going on. Try to figure out what they are. Document that stuff. That'll give you an idea as to what's going on, and it can tell you what you need to do too. Okay. Other things you can do for vital signs, you can take a BGL, blood glucose level. You're supposed to have a certain amount of sugar or glucose in your bloodstream. And if it's not there, that ranges between 80 and 120. If it's too low or it's too high. Are they diabetic? Are they hypoglycemic or hyperglycemic? Hypo means less, hyper means more. Like hypertension, high blood pressure, okay? Or the low blood sugar, hypoglycemic. You can also take a pulse oximetry, an SpO2 reading. That measures the amount of oxygen that's supposed to be in your air. That measures the amount of oxygen that's supposed to be in your bloodstream. Little light thing that we put on people's fingers, it gives a digital reading. You're supposed to be close as 100% as possible. Okay? If they're not and they're low, you can give some oxygen if you want to. Then you're going to reassess the patient. You're going to reassess the patient. If they're a stable patient, you're going to reassess the patient every 5 minutes. If they're unstable and you're afraid they're getting worse very quickly, then that makes them an unstable patient. You're going to reevaluate their vital signs every 5 minutes. An unstable patient you reevaluate every 5 minutes. A stable patient you reevaluate every 5 minutes. But if you want to do a little more frequently than that, every 10 minutes, you can do that. Okay? Reassessment. Reassess vital signs at least every 5 minutes or when patient's condition changes significantly. Sudden cardiac arrest is always at a risk. If a cardiac arrest occurs, perform CPR immediately until the AED is available. Reassess your interventions, provide rapid transport to the patient, and communication and documentation. You want to make sure that everything you see, hear, and smell, you document in your report. If it takes you half an hour to write your report out, then it takes you half an hour. Don't let anybody rush you, because that is a legal document. Okay, you can be pulled into court. If you saw something, you did something, and you did not record it on the report, then it never happened. Yeah, but I gave this medicine. I swear I gave him the medicine. Well, it's not written in the report, so you actually didn't do it. Okay? It's a legal document. You can lose your livelihood if your document is not accurate. Okay? Provide rapid transportation. Make sure you get to the hospital as quickly as you possibly can, but do it safely. You do not have the rights to run through red lights like a maniac. Tell your driver, tell your partner to drive carefully. Reassess your interventions. Is what you did for the patient correct? And if it is correct, is it sufficient? You gave them oxygen. Did you give them enough oxygen? Did you give them too much oxygen? You check their blood pressure. You check it often enough. Okay. Did you give the patient any nitro? Nitroglycerin is a drug that we can give with med control's permission. You have to call them. You have to make sure their systolic blood pressure is at. You need to make sure their blood pressure is at least a certain level. Systolic needs to be at least 100, if not higher than that, before you can give nitro. But that is something that we can do. But we assist the patient with their medication. But again, out of all the drugs you got to do, you always have to call med control to get permission. Tell them what you got, what your vitals are, and they'll say either yay or nay. Okay? Make sure you put the patient in a position of comfort. On page 651, they're talking about performing cardiac monitoring. We do not do that. We are EMTs. We're at the basic level. Cardiacs and medics do that. But there are times where they will ask us to attach the leads to the patient. Everybody's generally different on where they do it. You get 2 above and 2 below. Where they put them, everybody's a little bit different. You get a white dot goes in the upper right arm, and the black connector goes in the upper left arm. Then you have a red connector that goes on the lower right abdomen, and then you have the green that goes in the lower left abdomen. Sometimes the red and the green, they like them on the patient's legs, on the calves. Every cardiac or medic's different. They'll tell you how they want you to do it. But they're also, how can I remember what color goes where? Well, the black one, it says RA, right arm. The white says LA, left arm. And the same with the right leg and the left leg. The red will say RA, and the left would say, no, not RA, RL, right leg, and then LL, left leg. And that helps you remember where to put them. But there are times they're going to ask you to put a 12 lead on them, and take a look at figure 650. I guarantee you this is going to be on a test. I guarantee you. Okay? You have V1, 2, 3, 4, 5, and 6. Pay attention where V1, 2, 3, 4, 5, 6 go. 1, 2, you got the nipples right here. 1 and 2 go in between the nipples. Okay? You've got 1, 2, 3, 4, 5, 6. Okay, pay attention to where those go. Okay? Page 651, you can look at it real quick, but don't spend much time. This is not in our protocols. Okay. Sometimes the person's going to have a pacemaker in. Pacemaker is an electronic device that if for some reason the heart's not working right, it shocks the heart into a normal cardiac rhythm. A lot of times the pacemakers, they're just under the skin. They can look circular, or they can look in the size of 9-volt battery. You guys should have discussed that when you're doing CPR. Okay. Or internal defibrillator. You have a external defibrillator vest. It's actually a vest that the person wears, and it has the batteries and actually shocks the person. I've never seen one. You have AEDs, automated external defibrillators. You know what those are. EMTs carry those. They're all over the place. There are 2 things you do with an AED, and it's going to be on a quiz test. I guarantee it's going to be on your midterm. If you haven't already, it's going to be in your final. 2 things you do with an AED. You turn it on and you follow the prompts. The AED nowadays, they tell you everything what to do from the first step to the very last step. Okay? Make sure you're familiar with the 5 links of the chain of survival: early recognition and activation of the EMS system, high quality CPR, rapid defibrillation, early access to basic and advanced life support, and quick transportation to definitive care, which is at the hospital and the emergency department. Okay? Medical direction is a phone number you can call to ask for advice and to ask for permission to give drugs. Make sure you know what that number is. Okay, make sure you verify your truck at all times, that your truck is stocked and ready to go. Make sure that your AED has all the equipment that it needs. When you're doing CPR and you give somebody a shock, you're looking for something that's called ROSC. It's called return of spontaneous circulation. ROSC, or return of spontaneous circulation, is defined as the return of a pulse and effective blood flow to the body in a patient who previously was in cardiac arrest. Cardiac arrest. You got a bad guy, he steals from a store, the cops catch him, they put him under arrest, they put him in handcuffs. He has been stopped. He can't do any more bad. He's under arrest. He's been stopped. Cardiac arrest. The heart has stopped. Okay? Remember the difference between cardiac arrest and a heart attack. Can cardiac arrest lead to a heart attack? Can a heart attack lead to cardiac arrest? Yes, it can. Okay? And let's see, I think that's just about everything for the chapter. I don't know if you guys have any questions. I wish I could be there with you. Nitroglycerin is a medication that we can assist a patient with. It does have side effects. Make sure you study the medication guide that you were given in your class. Make sure you study the aspirin is another medication that we can give in the field. Make sure you review that and you're familiar with those 2 drugs, because there's numerous drugs that we can give. Make sure that you're familiar with the 5 routes or the 5 R's when it comes to administering medication to a patient. Okay. Make sure you don't get any make sure you never get any nitroglycerin on yourself, otherwise you're going to pass out. We talked about the AED. You guys have already gone over the AEDs when you had CPR class, so you're already familiar with that. You know that when you're doing CPR on an adult, okay, you're compressing by doing 100, 120 beats per minute. You're using 2 hands. And it's 30 chest compressions to 2 rescue breaths. And that is about it. So I hope I was able to explain everything in a way that made sense to everybody. I apologize if it seemed like I was tripping over my tongue and I was confusing. I'm not used to recording myself. So as these recordings continue, hopefully I'll get better. But I hope everybody's staying safe. Practice social distancing. Take care of yourself. Wear a mask when you're outside, or wear some protective covering for your mouth and nose. And take care of yourselves. Be safe, everybody. Okay? Now I have to get ready for the recording of Chapter 17. Take care, everybody. Have a great day. Stay safe. Bye-bye.